So this is a 72-year-old gentleman who presents to his physicians with fatigue and intermittent night sweats, along with the presence of lymphadenopathy. So he's examined, and on examination he has axillary lymph nodes that are enlarged, bilateral inguinal lymphadenopathy, and a modestly palpable spleen. He goes on to have a PET scan. The PET scan demonstrates the presence of enlarged lymph nodes above and below the diaphragm, including the presence of some bulky lymphadenopathy measuring 7.5 centimeters and a modestly enlarged spleen once again. And then he has a lymph node biopsy. The lymph node biopsy, we prefer the use of a full excision lymph node biopsy rather than core biopsies because it really helps the pathologist. This demonstrates him to have follicular lymphoma. Follicular lymphoma, we're able to grade depending upon the number of centroblasts that are present between grade 1 and grade 3. He has grade 3, in fact he has grade 3A follicular lymphoma. We're able to subdivide grade 3 follicular lymphoma into grade 3A, which is more common, and grade 3B, which is much more akin to diffuse large B-cell lymphoma, and we treat in a very similar way. Grade 3A we treat in an identical fashion to grade 1 and 2 follicular lymphoma. So he also has a number of blood tests, including standard biochemistry for renal and hepatic function, but also in order to help us in terms of prognostication, we measure the lactate dehydrogenase and the beta-2 microglobulin. We would do the usual virology assessments with hepatitis and HIV because, of course, we're going to use monoclonal antibodies, anti-CD20 monoclonal antibodies. We'll also assess immunoglobulin and urate. And the other thing that we still do in follicular lymphoma, despite moving away from in many of the lymphomas, is to do a baseline bone marrow test. And we assess the degree of infiltration of his bone marrow, which is common, and in this case he had 50% infiltration of the marrow. So in summary, he has stage 4B follicular lymphoma. He has B symptoms, so we have stage 4B disease. He falls into a high-risk group as defined by the FLIPI, the FLIPI-2 score, and also by the PRIMA PI. And that's because of the fact that the hemoglobin is low, because we know that the beta-2 microglobulin is raised, we've got bone marrow involvement, and a number of different poor risk features for this patient. So we fall into the poor risk group, and therefore that gives the patient a prognosis somewhere sort of in terms of overall survival in the high risk group of 5-year overall survival of about 50 to 60% or thereabouts. This patient tolerated maintenance chemotherapy given every 8 weeks with obinutuzumab very well, didn't have any infective complications, and by 12 months of maintenance therapy had converted from a partial response to a complete response, which is indeed promising. They completed a full 2 years of maintenance therapy and have gone on to enter a regular follow-up program. And that's really important. As I've said previously, we recognize that some patients do have early progression of their disease within 24 months of their initial immunochemotherapy. And those patients are patients who are at a high risk, in a high risk group. And we have recognized that from the gallium data that by using obinutuzumab rather than rituximab, we reduce the number of patients with early disease progression by using obinutuzumab.